Okay, excellent presentation. So now the panel is open for discussion.
Well, it's exciting, this topic, and we have in Czech Republic a group which now started a prospective trial. We will report soon about 10 patients we've done with CyberKnife. So I have similar experience as Andrea Natal, and we use fiducial point ICD lead, but the distal electrode, which seems to work quite well, and we have data on safety. Most of these patients is more than 1 year after this radiation therapy. There was significant improvement in burden, but there was no late toxicity, except of one patient where we are not still sure. There was a progression of mitral regurgitation in one patient, but otherwise there was a very good tolerability of the treatment. So I think this is really exciting area, and we described first patient with a fibroma, which was associated with VT, and it was quite a late effect in this patient after almost 6 months, gradually disappearance of. So there's not only acute effect, but in some patients you can expect very late, delayed effect in VT or change of substrate and disappearance of VT. So we need to learn much more than we know at the moment, but I think it's really very good area for research, for bailout procedures, like we do the same like Andrea does.
Joseph, you and the panel members, can you address the size of the area that you're targeting in terms of the net volume and whether that varies based on the clinical situation or not, and how that is determined? And Phil, if you can chime in related to the CardioInsight system, because again, you're targeting, emphasizing an exit versus an isthmus, and it may be different for ischemic versus non-ischemic. So just let's start that conversation in terms of how big are the targets, how much does it vary, and then how are you guiding the target formation?
Yeah, that's a lot of question to bake in there.
Yeah.
So going back to the discussion about the group in Czech Republic, it was fantastic. They were able to come to St. Louis and share their data with us as well. So we got to learn about that method and the results that they were seeing. And similarly, it's funny when we all start comparing stories in the 2 and the 3 and the 10 cases, you start to see some similar stories are being told, some similar results are being shared. We've also treated a patient with a fibroma, and it was a similar 3-month, 4-month delay before the VT started to go away. And so we're going to learn by doing this together. And that's, I think, the importance of clinical trials and the importance of global registries are going to be really important to move this together. You asked a very important question about size of target, and I think you're starting to see a couple different groups getting to some similar conclusions. Amanda showed beautiful data that more of the LV involved, at least at the 20 gray level, showed a reduction in ejection fraction over time in that preclinical model. We've done some preliminary analysis about the size of the targets that we've delivered, and it seems like the larger the target, the worse the survival will be. Whether that has to do with the underlying substrate of that patient already being sick, or whether it had to do with delivering higher volumes of radiation remains to be teased out. But I think what you're seeing as we start to compare notes, you're starting to see a need to be as precise as possible. And I think this is where you can't give up on the electrophysiology. I think in order for this to work, it's going to be much more than just a scar-based or substrate-based ablation. I think it's really going to be incorporating what we're learning in the EP lab to find those critical regions within the scar or at the scar border, and not necessarily driven by where the entirety of the scar is.
Yeah, but Phil, I will tell you this, that we don't even know the size of, Rod Tung did a nice job, by the way. I don't mean to denigrate what he just commented on, but that was the first time somebody commented about the overall global size of circuits, in a lot of detail. So we still have a lot to learn, despite the fact we've been doing this for 30, well, gosh, 50 plus years.
Yeah, and this is, I mean, it's a bidirectional learning process. I think what we pick up from the inside of the heart and from the outside of the heart with, mapping with catheters is directly applicable to how we interpret things like CardioInsight maps or how we integrate things like MRIs and CT scans.
I think we have, if I remember correctly, we calculated this target volume, and it was less than you had in your publication in NAME. So we try to minimize the target volume. Yeah. And because all these patients we've done were mapped before, and they failed ablation, so we knew where is the critical part of the circuit, or expected where is the critical part. So this was used for planning, and currently we are trying to improve the way how we export the data from the mapping system together with CT data to be able to plan it in a console for radiation.
But let me just ask you a question, Phil, in the panel. So we can image channels. Let's assume we can do that using different image modalities. How precise can you be? I mean, let's say if you have like a 1 centimeter, 5 millimeters, how precise, like laser focused, can you be with this therapy?
Okay, so I can answer that two ways. One, I'll give you the two smallest volumes in the group that we just treated in Encore VT. So those were the two patients with PVCs. So these were not the sustained VTs, but these were the PVC cardiomyopathy patients. And the target volumes were 6 and 10 cubic centimeters, and that was, again, we talk about volumes as if they're perfectly prescribed, but that was the prescription dose for the 25 gray that was delivered. So 6, 10, I mean, the radiation oncology teams are amazingly precise, particularly with tumors that don't move. Mm-hmm. When you introduce motion, there's a little bit more uncertainty that goes into that. But if you want to be very precise, I think that our radiation oncology colleagues have learned over the course of these last 20 years about how to really deliver precision radiation. But the question that I would turn around and ask you is that what we need? Because catheters do that really well. Right? Catheters give me a very precise sort of way. So I think we want to understand how precise we can be, but I think the value here is this is an energy that can be delivered to the full thickness of a tight area. And we're going to learn more about what's happening at those edges, but it is a full thickness radiation delivery. And I think there's advantage to that.
Yeah. Sorry, go ahead. I think that there is no doubt you can be super precise. I think the issue, the point I was trying to make is that I don't want people to think that there is no scatter radiation, because there is. That's what I was going to try to show you. And in that patient, we kind of underdose the area of interest because of the vicinity of the stomach. And this is what we really don't know. And we are not going to know in 1 year, 2 years, or 3 years. This is something that we have to look over a span of 10 years, if that makes a difference, because the amount of radiation that the surrounding structure get is not irrelevant. We didn't have time to go all the slides. There was a slide showing that the local radiation that you give is 20 times higher than what we give with a VT ablation. So those are the issues that I have, and that's why I actually am trying to convince my system to look more in proton therapy for the reason, although I'm not sure if I see this correctly. And obviously with proton therapy, the cost is one of the issues. Our system has 2 proton therapy in England. I don't know, we're trying to see if there is any in the States, but I try to convince our hospital to actually invest in proton therapy for that reason, although maybe you can comment on that, if that really makes sense in terms of addressing this issue of sort of the radiation that we deliver to surrounding structure that are close to the heart.
I think we have these questions in radiation oncology as well, because there's x-rays in every radiation oncology department, and there are less than 100 proton and carbon centers around the world. So we're always deciding which patients benefit most and trying to channel the resources where it makes the biggest difference. So I think it's going to depend on target location, target size, age of patient, other risk factors, And it'll be a tough decision going forward, figuring out which patients are better sorted to which technology based on availability as well as cost.
Go ahead. But I just want to ask, what do you think about the tolerance business of the surrounding tissue and the non-muscular part of the heart, the blood? Do you really have a good handle on that with absolute certainty, so that you can sort of go back from there and say, listen, if I avoid the delivery of that level of energy to these structures, I can target anything I want to in the muscular area, because I know if it's not too much, I won't hurt the heart, and it may allow collateral damage to be minimized?
So I don't think we know that answer yet. Because we're not treating these doses in radiation oncology patients, we don't have the same comparison. We know that breast patients, 5 gray delivered over many fractions, will have a higher risk of coronary artery disease in the end, but how applicable is that number to this patient cohort in these doses? So as low as reasonably achievable, and we'll try to figure out those dose lines as studies go on and we get the data.
This is Dr. Sampson's been, she mentioned she's been looking at the cardiac substructures and trying to get a sense, because of that. This idea that we're just applying radiation to the heart doesn't really make sense. So breaking down by valvular structures, each of the individual coronary diseases, each of the individual components of the heart, I think are going to be important for us to learn moving forward.
And in addition, the prescription dose, the 25 gray, any hot spots or areas that are slightly higher than that, we must confine to the treatment volume and not let it be outside that. So that's another mechanism we try to.
Ed, and then Vivek.
Just a quick question, great session. Any work being done in terms of gating? It seems like one of the challenges is cardiac motion, gating the beam to the cardiac cycle. And I've heard, at least for proton beams, it's hard to gate them because you need a big slab of lead. So is it feasible to gate these other energy sources? And have you looked into that for gating the X-ray?
So I'm going to take a cardiologist stab at it, but the two next to me are experts at it. But I'm going to try to explain it in a cardiologist way. So yes, you can gate. Right? You can do cardiac gating, you can do respiratory gating. It's far more common to do respiratory gating if you're treating lung tumors that are moving up and down with respiration. That is, you could go beam on when the tumor or component of the heart is within a certain cycle of respiration, and then you could go beam off when it cycles out and kind of go back and forth. Alternatively, what we've done is we've done a 4D CT scan. That is, we know where the region of interest in the heart is with breathing in, breathing out, systole, diastole. So we've got the entire motion envelope mapped out with a 4D CT scan. And for these patients who have no other options, we've taken an approach of we don't want to miss. So we've created a little bit of a larger volume in an effort to treat the entire motion envelope of the region of the heart. So that allows you to deliver energy consistently, constantly. Gating takes time. Each time you breathe, you're beam on, beam off. But if you treat the entire motion envelope, you can treat in a very short period of time. There may be biological reasons that might be advantageous, but there certainly are practical reasons when you try to get somebody who's got class 4 heart failure to lay flat for 7 minutes versus 90 minutes.
What about pacing rapidly to reduce the excursion of the heart, and maybe that would help?
Yeah, but this is the reason why we use that sort of external lead, or now we're looking at existing leads. So that's really to maximize the gating of the heart motion. So you have an intracardial lead that you use as a reference to sort of gating that to.
Yeah, but your question was more about pacing to paralyze the heart to minimize motion.
Yeah.
I don't know if it.
7 minutes of pacing at 200 is probably a little fast.
Yeah.
So, but you're right that there's ways that we can think
Make
about
it more specific, perhaps.
Yeah.
More
I don't think with the external lead with the cyber, I don't think we have seen in the animal testing any significant sort of issue. I think the problem is that for the most part, you have to sort of instrument the patient invasively with a temporary wire. Although it seems that existing lead can be a potential alternative, but with the temporary wire, in experimental model, actually, we haven't seen any issue in terms of accuracy and in gating for the heart motion.
I can just comment. I think the main problem is respiratory movement rather than heart movement. And there is also difference between these two different technologies. I think you use a different technology which is shorter, and we use CyberKnife, which all the time recalculates depending
Yes.
on the movement of this fiducial point, which is a lead of ICD in our case, or external pacing wire. So I think that is quite different, but both somehow correct for respiratory movement. We believe that CyberKnife is more precise because it
this is the
recalculates.
idea
It
is
takes
it's
much longer.
Yeah.
It can take, if there is a lot of recalculation, it can take 1.5 hours
Yeah.
to irradiate.
I would make one quick comment about physical gating. For X-rays as well as protons, the source is a LINAC, and we can turn those things on and off. It doesn't require additional shielding. What you need is a predictive filter, and you need, an on-off switch and some way to feed that signal in and to check the effectiveness of the filter. Possible for both, just not easy.
Vivek, last question.
Okay, trying to decide which is the most important one. Let me ask you this one. So other than cost and availability, what is the disadvantage of proton/carbon therapy as opposed to X-ray beams?
I think one of the main things that we always keep an eye on is we are exquisitely sensitive to how deep something is. So if a patient gains a lot of weight, if you're shooting through an area where the external contour is changing, if the path to target is 2 centimeters when you plan and it's suddenly 5 centimeters, your protons are still going to only go 2 centimeters. And so I think there's more of an awareness about that and what sort of beam angles we can come in. And that's another reasons for deciding when it's appropriate to treat what tumor or what site with protons versus X-rays.
And especially in heart failure patients too, who may have various volumes between the day they were simmed and the treatment day. That's another consideration.
And lastly, I'll throw this one out there. Protons generally don't, they cause more trouble with the defibrillators that are in. There's more neutron creation on patients who are getting proton therapy with defibrillators already in. And so there's more soft resets and some of the other changes that we might need to be aware of with patients with defibrillators.
That said, we've treated a lot of patients with devices and we're still doing okay.
Yeah.
But we're aware of that danger as well.
Outstanding session. Thank you.
Good. Thank you.
Good way to close.